Started. Um, we have the pleasure of having Dr. Dugard-Galt, Marianne, here today to talk to us about genetic testing for breast cancer and the risk of breast cancer in 2021. She's the medical director of the Cancer Genetics Service here at SCCA, and we are so lucky to have you. Thank you so much for coming and talking with us.
Thank you. Thank you for having me in. I wanted to maybe talk a little bit about those two parts, and I'll put the outline up of the things that have been happening for breast cancer and the things that have been happening for at risk of breast cancer. And then, you know, a lot of things have happened really in the past few years, and then last year was really a big year for a lot of those larger studies coming out. So there are a few very interesting studies that has helped us refine some of the things that we do and will help going forward. Just a few, the outline of what we'll talk about on the stage 1 to 3, and then the progression of disease in stage 4, and the Olympia trial, obviously, as it will probably change everything we do going forward. And then we'll talk a little bit about this 10 genes for breast cancer risk and the different things that we'll do for screening and fertility and other things going forward. So for breast cancer, this is the table that was presented right for the Olympia trial that was testing a BRCA status before deciding on what to do for treatment, and the goal was to be able to triage patients between having olaparib or placebo, nothing, after they completed their treatments if they had either high-risk disease, triple negative histology, and other markers that would suggest they are at a higher risk of recurrence or other things progression-wise. And so this is here the first, I think it's the first study, right, that we have actually done the BRCA testing upfront right before, you know, people have their testing for all patients, not just patients who had a family history or patient who had things going on for their own family or other things. So it really is one of the princeps or trial studies that will actually set the pace for how we're going to do it forward. So BRCA 1 and 2, both groups had a significant portion of the 1 and the 2. More, to me, the BRCA 1 group makes more sense that they would be in a breast cancer study because the risk of breast cancer is much higher with BRCA 1. So that's why you don't see as much BRCA 2 that is more common overall in the study here. The adjuvant treatment that people received, pretty good between the two groups. And then the mostly premenopausal women. And then this is the disease-free survival between the two groups, and this is very exciting, right? At year 3, there is quite a difference between the group receiving olaparib versus the group receiving placebo, and for triple-negative disease specifically, that is very encouraging. And this is in this table here, some of those further details in the group with the placebo versus the group with olaparib, and then the treatment that they had received. I highlighted in this with this arrow here the triple negative patients, a significant number in the olaparib group and then the placebo group, and that the odds ratio and the interval of confidence is quite moved towards the olaparib side. Same for people with a BRCA1, and it goes with the triple negative histology or a pattern of the breast cancer. And then here for the CPS scores or some of the things that are more related to how immunogenic the tumor would be, also moving closer to the olaparib being better. And we'll talk a little bit about that. And then I wanted to share this with you because this came, I think this is a very recent paper that was published 2 or maybe a week ago in the British Journal of Cancer, trying to measure the risk of recurrence or contralateral disease going forward. And so they had 800,000 women in the SEER database. So they went from the SEER database. They had 650,000 women with invasive disease initially. So 150,000 had DCIS, and then they actually, over this 25-year period of time, at follow-up, they had 25,000 new diagnoses of breast cancer, so 3.2%. The median time between the first and the second, 7 years, and the calculated annual risk of breast cancer would be 0.4, and a cumulative risk of 10%. I argue that, you know, the hardest part is to identify who will have the cancer when. And one of the things they didn't do in this particular study is have the status or the genes or the genetic predisposition there. And one of the things I went back and did for the paper of the olaparib or Olympia trial is I went back to look at the adverse events, and specifically the ones for if people had cancer coming up after they had their first treatment or things for the breast cancer. And interestingly, they had a few diagnoses of new or second primary cancer in those groups. And then I went back in the supplementary table to find what cancer people did have. And you can see here, I'll talk a little bit about the MDS AML later because we know PARP inhibitor can actually change the risk for the future. But specifically for a second primary cancer, this is really interesting here where, some of those patients with BRCA1 and or BRCA2 or other genetic predisposition markers will have other breast cancers within that short period of time of 3 years, whether it was already there or not. And maybe a difference between people who were on olaparib because maybe it took care of some of their cancer diagnoses or whatever was going on. And so this is, to me, this is very interesting, saying that there were things going on either in ovaries of patients or the other breast or other parts that would suggest that the status, the genetic status is important for the risk stratification going forward, and it's not all equal for women who have a genetic predisposition. And then maybe the difference between this group, the placebo group, and the olaparib group is that maybe the women here are followed closer, they're sent to BOCP or other clinics that we have, right? For example, where we can actually do the risk-reducing surgeries, and it's possible that these women are followed, and they're not always kind of taught to get their genetic testing or other things, right? And so have the risk of some of these cancers show up. And this is actually the other part I wanted to bring up is this patient, Rachel and I, Dr. Young and I share. This is a woman that is now in our high-risk clinic where we follow her, and we are finding that more often than not, there is more than one thing going on, right? So this person, she's 64 now, she presented with her first cancer, she was 40 or something like that, right? She had endometrial cancer, and then I believe she had the breast cancer second, correct me if I'm wrong, I think it was breast cancer second, and then she had the gastric cancer on her first screening for GI cancer after she was found to have a PMS2, that's the top variant here. So she had this PMS2, she was going through her treatment for breast cancer. People, Dr. Bill Grady or Dr. Brentnell did the upper and lower endoscopy, found a gastric cancer for her. And I think more recently, as we've followed her, she's been going through her fourth cancer, so fourth separate primary cancer of the rectosigmoid junction, I believe. And actually one of the variants that I put here on the side that she has is, to me, very suspicious. She has this STK11 that's a splice site that's very, very conserved. And all the models predict damaging effects of the variant. And then I talked with Dr. Brian Schurz recently to ask if this was something that was upgraded or reclassified, and so far it's still PUS at this time. And then when you look at the things to say, well, maybe this is a benign thing, shouldn't be too much of a big deal. It was present in NOMAD, but at very low frequency, and not a frequency we would have expected to be something that it's higher. The frequency for this disease, I think, is higher than this. So this is something that would not help us make this variant benign. And then it was also reported in a case or a patient with a BRCA2 frame shift, which shouldn't be used to decide if this variant is benign, because we know that people can carry 2 or more predisposition or high penetrant variant in themselves. And so for her, one of the highest risk is really this lifetime risk of pancreatic cancer if she was to have this after having had 4 cancers already. So that's a plug for the high-risk clinic where you have this approach with all of the organs together and doing the screening and surveillance all in one place to really be able to cover all the things that patients are at risk for. All right, and then on to now that we're talking a little bit more about progression of disease and or stage 4 or when the treatment is not working. If we are talking a little bit about the DNA damage and the PARP inhibitor creating those immunogenic cells, and we can harness the PD-L1 or the immunogenic response to really add lethality to the synthetic lethality that's already there, to really potentiating the effect of a PARP inhibitor and an immune checkpoint inhibitor. And this is a paper that was published recently, putting all of this together with all of the pathways in the figure. And then if you have different treatments, the alkylating agents, or some of these other repair pathways that are involved, you can actually tailor which treatment to give the patient based on what alterations they have, BRCA/NS for mismatch repair, and really add to the effect to help kill the cancer. And one of the this is one of the tables in this paper where we have the different clinical trials that are ongoing with the different combinations of treatment here, and looking forward to hearing how these patients do. And then talking a little bit about the mechanisms of resistance for patients who have long response. And I know you guys have a patient like this where she was diagnosed I think she was treated and she's been disease-free for over a decade. And I know Dr. Swisher, many other people have had patients like this where, and this is a paper from that was done I think recently, where they put it all the treatments, all the different alterations, and the different steps the patient had over this nice historical chart. And so you see that over time she was diagnosed. She was found to have the BRCA2 pathogenic germline variant. After some of these treatments were done that were more the standard of care she would have received. And no, the genetic testing was initial, so she had her bilateral mastectomy, and then she had the somatic profiling on the tumor, and then it was positive, and then she was then a candidate for PARP inhibitor, and she's received PARP inhibitor for a long time until the PARP inhibitor wasn't working anymore. And then when they looked at the different samples and did the comparisons of what was present in the different samples, you could see that she was the germline alteration had removed one base pair, so it was a frame shift alteration, and then that in the tissue, the base pair was reversed, so there was a repair mechanism in the tumor to really be able to reinstate or turn on or put the reading frame back on, so then the BRCA2 would be functional again. And so I think this is where we're headed in terms of really using some of these tools, whether it is the tumor profiling, the germline alterations of some of the things together paired to be able to tailor the treatment patients are getting. And then this is more recently I was hoping the paper would come out, and this is the SMART program, where I just wanted to highlight here that they did try to get as much information, genetic information as possible. And it took quite a number of steps to get there, right? The sequencing panel, the whole exome sequencing from Tempus, the TRUE-seq RNA exome from Illumina, and then the proteomics multiplex protein analysis to be able to come up with as much information about the tumor as possible to create the best plan for the patient. And I find that very hard to do. I think they did this for 53 patients or something like that. It's hard to do when you have to send many different things at many different places and then bring it back and all together. And here we do have the expertise for the tumor profiling, the germline predispositions, the RNA-seq with Merrick King's lab and Tom Walsh, and the transcriptomics at the Hutch, right? So we have all of the expertise that we could bring together to be able to do things like this. And then a little bit on the risk if you were to be on a PARP inhibitor for a long period of time, or if you had a predisposition that was also present in your bone marrow and you had clonal HRD deficiencies in your bone marrow, what would be the risk long term to have synthetic lethality or medications like PARP inhibitor added to your body? And so this study it's more of a meta-analysis. So it brought all of these studies from 2012, 2019 together. The number of patients is pretty small overall, and maybe there are different patients who had different lines of treatment. Maybe they have a lot of things going on as well. So I don't know if we can compare all of the patients together, but there is a trend to suggest that maybe having PARP inhibitor or taking PARP inhibitor may increase the risk of MDS AML for some of the patients who either have a germline predisposition and no clonal alterations, or maybe they have clonal alterations already, and you're boosting that alteration to cause some kind of a transformation in the clones of the bone marrow. And so here the confidence intervals, they're not very good, right? But they're suggesting that maybe there's something there, and this is information we should kind of continue gathering to help decide who would be best candidates for PARP, if we do need to do any other kinds of testing, and what would that imply. And they tried to also, I won't spend too much time on this, they tried to see if there was a difference between different PARP inhibitors. I don't think there's enough information here yet to see that. And then the things that I think we don't do as well yet, that we'll probably do a lot more in the future, is not only you can have resistance to medications like PARP inhibitors or other medications because the system, the tumor, found a way to escape that mechanism that was helping it be killed. But you can also have people who don't either tolerate medications well, so they don't take it, or they actually don't process the medication the way it should be processed to be able to have the actual function, right? And some of the things that we don't test right now that may actually be important in the future is how people would actually tolerate anthracyclines or other medications for their risk of cardiotoxicity. And eventually, this is something that would be very helpful to find out. So you can tailor, someone's going to have 12 shots, 12 months of Herceptin. How can we predict if they are at higher risk of having a cardiomyopathy already? How can we help send them to cardiology, make sure they have the right things already teed up, maybe change the dose or adjust the dose as they go and things like that. And then I also wanted to bring as we are all bringing a lot more information together, getting this pharmacogenetics information and getting some more exome or larger kinds of studies where you're studying the tumor, but you're really studying the whole body or the whole genome together with the tumor's genome. There are a couple of groups and the eMERGE consortium specifically that are trying to bring out some guidelines on what to do when you do larger studies like this and what should be reported, how common are these findings, and where to go from there. So the eMERGE consortium, I'll show you the map. So many different centers are a part of the consortium. Dr. Gail Jarvik at UW Medicine is the local PI for the study. And I'll show you more recently, they actually published the secondary findings. So when you do a large study, genetic or genomic study on an individual, what comes up and how often does it come up? I'll show you. So for the frequency of secondary findings, so the things that we didn't necessarily look for specifically when we did the study, but we found incidentally that has actionability and things we should return to the patient. And so this was one of the very cool table from a graph from the paper where very commonly you would find a BRC2 variant. You could also find a BRC1 variant and a PALB2 here in the population. And I think this was 21,000 people. Yeah. And so, and then I'll point your attention to this other genetic variant here, this MYBPC3, or the one for HFE, that's hemochromatosis. But this one for MYBPC3 is one for cardiomyopathy. And that's also something that would link some of these things together, right? If you're going to find more people, when you find these particular variants with familial hypercholesterolemia or cardiomyopathy, when you start doing a large assay on your patient's tumor, this is something that needs to be confirmed, or things that we need to address for the patient themselves, for their treatment, and for the family members, because those predispositions are recessive or most often dominant. All right, and then, oh yes, and then this is a pie chart of the number or the percentage of positive secondary findings, and those are likely pathogenic or pathogenic, right? There are no VUSs, nothing of the sort in the reporting back to the patient. And then I brought here the table. So there's 73 genes that are recommended to be returned to the patient. So they're actionable and recommended to be returned. The PALB2 gene has been called the BRCA3 more recently, right? And so it's the first time it's made it on the secondary findings list. And some of these are the ones for cancer I cut off, but they're also on there, P10, V5, and other things. And then the other thing that I put on there is, see, these are very important, because if you do find a hereditary cardiomyopathy in someone, this information really needs to go back to the patient. And so I'll talk a little bit about that, but having a framework to be able to, if we identify these, how do we go forward from that, and how do we take it to the next steps for the patient to know, for the family to know, and for us to see the patient to do their testing. And this is a most recent study that was published actually by the New York Times, and Everett was interviewed by Susan Berger here for talking about awareness about the gene PALB2. And then this is a smaller study, but I really wanted to bring it up here because it changes, knowing your BRCA status changes outcome, right? And this is a study that was done by Dr. Levi Lahad in Israel when they have the capabilities of doing BRCA testing earlier, or for more people now, because it's part of the things you can just get to with your primary doctor. And so what they did here is they had women diagnosed with breast cancer before, and knowing and they knew their BRCA status before they were diagnosed with breast cancer, and women who did not know their genetic predisposition status before diagnosis of breast cancer. And you see here, the ones who did know were identified on MRIs more often than breast exam. And they had actually a significant portion of BRCA, of estrogen receptor positive, right? And then the clinical stage actually striking, right? The more often T190 rather than greater. And I think that speaks the loudest to me is that if you do the pathological stage, even though they're small groups, right, you have more often than not a PT2 or PT3 after, finding out your BRCA status afterwards. And more often than not, you'll have a PN0 if you knew your status or were more aware about the risk of breast cancer. And then here, 60 or 55% here didn't need chemotherapy. And this is a small group, but very, very striking to say that it makes a difference. All right, on to genetics for at risk of breast cancer. This is the most recent paper, and I'll put both of these papers together, and then we'll talk about those 10 genes for breast cancer. So this is the first one that was done for the 113,000 women in the UK, I believe. And so the differences here for the absolute risk of breast cancer was confirmed for BRCA and BRCA2, as we knew, no surprises there. But PALB2 actually really rose very close to this BRCA2, and we're starting to see similar patterns, right? Ovarian cancer, prostate cancer, pancreatic cancer with PALB2 that are making it suggesting that these two genes probably work very similarly, and so we should pay attention to them in the same way. So doing the screening the same way for patients who have a family history of pancreatic cancer with a PALB2 or prostate cancer, things like that. And then, as you see here, some of those genes that we have on the panel, or that were part of the genes for breast cancer, NBN, FANC-M, and other genes like that, those are kind of coming down on the risks. And so some of these genes may actually not have as strong a risk as we anticipated before, and so some of these things may not be on the NCCN guidelines in the future for MRI screenings or other things like that. And this is the news and view from Nature and Dr. Fouts in Boston. So for the 10 genes of breast cancer, right? This is the study I just showed you before, and this one here is this study here. And so it depends on who's counting and what genes you count, but some of those genes actually have panned out, and they will stay on the panel for the risk of breast cancer, and some of those genes will not test going forward and may actually fall off. So you may see that soon. All right, and then also very timely for us to talk together today because the NCCN guidelines came out for the 2022, right? And so when to send people for genetic testing. If you know the variant, obviously, right, we do this all the time for the updated testing for people who had only BRCA1 and BRCA2. Often enough, it's always a good idea to send them back because there are family members to be tested or other things like that. If you have a suspicious mutation on tumor profiling, that goes back to the thing I was saying before about what to do if you have something that looks really suspicious, like a truncating variant or something like that, and then to aid in surgical decisions, chemotherapy regimen. And that is directly correlated to the Olympia trial. And the criteria-based are probably similar to what was there before. You need to go back in the details, but overall, very close to what it was. And then this is the main tables or the main testing criterias. I would say often enough, people don't know very much information about their family history. So if you count something like this with unknown or limited, you probably offer testing to a lot more people than we do now. And then this particular slide here, so any age for triple negative breast cancer now, not under 60. And then to aid at treatment decisions for PARP inhibitors, so any person who's progressing on their line of therapy who would, maybe benefit from a PARP could have the genetic testing. And then to make for the high-risk disease or high-risk patients with a HER2 negative, triple negative, and other patients to aid in their adjuvant treatment therapy. And then I added something here at the bottom because I think that's also very important. I've joked with Dr. Jenny Cruz that anybody who walks through the door was already had a cancer diagnosis. Any cancer diagnoses should actually be seen in genetics, right? So personal history of cancer is a suggesting sign that they will probably are at higher risk of having the cancer they have now, or they were at high risk of having the cancer they have now, and then maybe other cancers later down the road. They should come to genetics. And this is one of the abstracts, and the paper is coming out soon. This is from the Memorial Sloan Group and Dr. Cadu, who's now in Ireland. So they did, out of the 25,000 people in the database at the time, they pulled all the people who had more than 2 cancers, and they removed all the basal cells and all of that. And they looked at how many cancers people had. There was a strong enrichment for people of Ashkenazi Jewish descent here. And then they looked at the median age for diagnosis, and then they tried to pair and see how likely was the second cancer to occur if we would have matched it with the SEER database incidence for those cancers. And so what came out for breast pancreas, that's probably the BRCA2, PALB2, or ATM or other genes. Breast, so the first primary and then the second primary for the BRC1s and BRCA2s and PALB2. And then breast thyroid for P10, for example, or things like that. And breast colon for maybe some other genes that we don't know. Or maybe a mismatch repair problem with some other really high risk for breast cancer where we haven't found the gene, we don't really know if it's a polygenic kind of disease, and so then some of those things may actually be a higher risk than baseline, and we wouldn't have a clear genetic idea of what the genetic mechanisms are. And then this other paper there as well for early onset and young adults with cancer, when they looked at about 1,200 cases of early onset cancers, right? Most common cancer, breast cancer, and then most common gene, BRCA2, and then when they looked at the younger adults with cancer, I think those were age 40 or younger, I believe. Those cancers for maybe leaf harmony or P10 came up, and the most common gene was TP53. And those are germline, they're not somatic TP53. And then the other testing criteria for ovarian cancer, basically all. Even if you have a family member with ovarian cancer and let's say that person is not ready to do their own testing. I actually had a patient yesterday that returned positive. When she herself had ovarian cancer, her sister and family had a BRCA1 in the family. Most likely she was going to be positive, but it took her 12 years to be ready for genetics. And she's positive, obviously, for the familial ovarian. And so, and then for pancreatic cancer susceptibility, same thing, either everybody who has pancreatic cancer or first-degree relatives. And I'll show you an example of a patient that I saw solely on the basis of her having a paternal grandma who died of ovarian cancer at age 54. She was seen in breast health initially, and this is the Tyrer-Cuzick that was done then. And so family history of ovarian cancer, no breast cancer whatsoever, patient was 35, with the anthropometric things that are normal. She just hasn't had a child, been pregnant, and turns out she's actually positive for the BRCA2, which changes her lifetime risk of breast cancer altogether. Right? So important to have the therapeutic in the light of the genetic results, because the genetic risk can really change the interpretation and the assessment altogether. And then a few words on the polygenic risk scores, because I don't think that going forward we'll be able to avoid ordering them and using them every day. So this idea behind the polygenic risk score, as you all know already, is that there are probably people who have a higher threshold or have inherited a higher number of these genetic variants all across their genomes from one side of the family, and that raises their likelihood enough that they would cross this threshold to have a diagnosis of breast cancer, even if they don't have a genetic single gene predisposition to breast cancer, like a BRCA1 or BRCA2 or some other genetic markers. And so if you pull all of these genetic markers together, you can come up with a score. And so then this is from the genome.gov website. You can put people on this like Gaussian curve, where I put this this is not part of the original picture, but this 20% lifetime risk of breast cancer, if you imagine that all of these people here are above that line or threshold, then maybe they would benefit from, not being here and have their annual mammogram, right? They should really maybe have MRI screening and clinical breast exams or mammogram. And then if you decide that 25 maybe is the correct cutoff, or maybe it helps decrease the number of scans we do for people who may not need to have scans, then this is very helpful to be able to, highlight or identify people at the tails. People really wouldn't need them, and people really would have inherited a higher burden of risk with all of these markers to accumulate or to have a cumulative risk that is much greater than what we anticipate their risk would be otherwise. And so this is actually received a lot of press, and so there are different polygenic risk scores. I put this picture here, and you've seen this one before, where this is a prediction of the people's risk of breast cancer up to age 80 if they have one of the single gene predisposition, and then on top of that, the group there measured 86 of those SNPs to see if that risk was greater, different, or smaller, right? So this is a nice illustration of how the polygenic risk score can actually put you, if you're, let's say, a non-carrier of BRCA1/2 or PALB2, and if you have a lot of these markers, and you may very well be above that 25% threshold and meet guidelines or criteria for the screening, whereas if you are maybe a PALB2 and you don't have a strong family history, or maybe you didn't inherit a lot of these markers, maybe you're not as close to that 60% lifetime, and maybe this is something that would actually be helpful for the patient to know, even if they would continue the screening the same for now. And the one thing I want to point out here from all of these polygenic risk scores is that they were all validated in a white ancestry, right? So the polygenic risk score for this study here, you see the 18,000 people that were used to validate the score or develop the score was 75% white, no African American, or very little. And same thing for the validation cohort. So this is highlighting that the use of polygenic risk score shouldn't be done for diverse ancestry. And the assumption was that if we could find the polygenic markers in one cohort, we could apply it to another cohort, and that's not true, right? So we know that when you try applying a polygenic risk score to different groups, you actually lose in accuracy of your prediction. And so this is a paper that was published recently on how we shouldn't use, we should have different risk scores for different population and use some of these markers based on the information we have cohort dependent. And then this is also to show you that the information used for those risk score calculations are often coming from a very large cohort of people, European. And then recently, Mercy and I have looked into the numbers of things for our own group here, and I think we came up with less than 2% of patients out of the 8,000 referrals we've received so far were coming from public view, for example. So really have to maybe do a bit more in terms of reaching more people more people from different backgrounds so we can actually offer them a single gene evaluation and some of these other things, like the studies I'll talk about in a second. This one. So Dr. Gail Jarvik, as part of the eMERGE consortium, has this study that is going to come out live soon, hopefully, where the idea is to enroll 2,500 individuals, specifically individuals with or from minorities within the UW medical system, to be able to do this polygenic risk score for 10 genetic conditions. Some of them are cancer. I think there are some cardiovascular ones in there. And with the goal to return those results and measure or look at what the outcomes are going to be. And I think it's for adults and kids, if I remember correctly. So looking forward to doing a little bit more of that, and also be on the lookout, because I think they will probably enroll patients with breast cancer for the validation, right? So I think this is coming our way very soon, hopefully. A few words on the premature ovarian insufficiency, because there was a paper published recently that confirmed something we had in mind that would actually affect, that BRCA1 and 2 would affect fertility. And it turns out when they measured in people who had breast cancer, whether they were BRCA positive or not, the BRCA1 had lower AMH levels, and they had lower ovarian reserve. So this is something we talk about with patients now, specifically if they're trying to plan when they will have babies and maybe not delaying it to 40, or to do preservation of embryos or of oocytes, because it may actually matter what the amount they start with for the future. And in this also recent paper about the PARP inhibitor and how it may affect the function, the ovarian function of the oocyte themselves, it's very possible, and this group shows that PARP inhibitor will actually change the number, the quality of follicles, and maybe the likelihood someone would actually be able to have a pregnancy. So if a patient is planning to get pregnant and they are about to go on PARP inhibitor, this is something that's very important for them, because it may very well change the actual embryo, or the oocyte themselves and the embryos. And it also changes the genetic markers in the follicles, and we really have no idea what it does, right? So some of these things may actually change the receptors, or some of these other things with the methylation profiles that may have significant consequences for the future baby. I think the few next slides are really where to go from here. How do we bring all of the things from the tumor profiling, the markers, the polygenic risk scores, all of these things together, or how do we kind of combine our efforts to really advance some of the things that we do for our patients here? And I put this is the steps for the Commission on Cancer that we are accountable to do anytime someone gets a genetic test, right? You're supposed to be able to identify all the patients at risk. You're supposed to provide the pre-test counseling, and then they define who can actually provide pre-test counseling, the informed consent, the test ordering, and then the disclosure and post-test counseling. And I propose that, for all patients with breast cancer, we could have this pre-test video that would help highlight what it is that this genetic testing can do, and then have this, if there's any questions or anything that comes up, they have a referral to genetics. Or if there's any particular insurance issues, whatever it is, they can be referred to genetics. And then have a consent form if they have no questions and they're ready to proceed, because we know that 1 in 10 will be positive, right? So the 9 out of 10 may not need to see genetics at all. And have the clinical research consent form based on they're ready to also provide a sample for research or not, and then we would see the patients with a positive or VUS result. And so for both, if people are only signing up for the clinical part, they get the ovarian panel or breast and ovarian panel. They sign up for the clinical and research, they could have the breast and ovarian panel plus other things later or right away, and then we would see the patients for the results. And this is the registry that I just want to briefly mention. This is something Lauren Santos and I have been working on, to have a place where all patients and all of their information could actually be logged in, their genetic information specifically, and then have their consent to return results to them, or to return results to their legal next of kin for pancreatic cancer, for example, where most people are, have we find them positive when they're metastatic, they're at the end of their lives, and so it's important to have the mechanism to return the results to them or their family. and enroll in future research. So, you know, the idea is we would actually have this baseline consent form that would really englobe a lot of things we could do in the future at the time of their cancer diagnosis or whenever we follow up with them, so we can actually take it to the next level. I think that's it. I'll stop here and ask you to share your thoughts.
Getting some claps. That was really an excellent presentation, Marianne. And just opening it up for questions. I have some.
So I have one for Marianne and maybe for you too, Rachel. If I have somebody who's a BRCA1 mutation carrier who's had breast cancer and where I finished her systemic therapy, what's your threshold for when you would come back to these people with a lap rib versus saying, you know what, it's been too long? Somebody who's already had prophylactic mastectomies and TAH, BSO. You know,
I don't know if we know the answer to that. I find that it's easier when they're right there at the treatment, right? And then when you have to go back, there's not much, you know. And we have a patient, I think Dr. Linden has a patient like that, where the treatment, the PARP option comes right there when everything is finished or over, right? I don't know if we have good data to suggest or to guide us to do that.
No, I don't think we do. And I was wondering whether or not we have some sort of sense about how we want to do this, because this is not the first time we face this in breast cancer, right? Where people have finished their active therapy and then something new comes on board. And, you know, sometimes we've used 6 months, sometimes we've used a year because that's what we picked. And so I didn't know whether we as a group had any sense about, you know, I'm kind of feeling guilty about the patient or two that I've seen recently like this and wondering whether I should have said, oh, by the way, this trial came out, even if they've been done with their systemic therapy for 6 months or a year.
And Nancy, I think you bring up a really good point. And I actually was just during the talk kind of taking a peek again at the Olympia data and sort of figuring it out. You know, oftentimes we have these trials that go on at the same time. So the CREATE-X data came out. And so I think the other question is how do you pair something in terms of thinking about adjuvant therapy for triple negative breast cancer that don't have a pathological complete response? So Olympia only looked at high risk cancer, non-HER2 positive without PCR. And so I think the other question is, you know, what do we think about for the population that doesn't explicitly address? And in terms of the timing question, the only thing, and I'd have to take a look at the curves again, but what I remember taking away from it is that the curves diverge quite quickly and actually hold on to it, which makes me a little bit less eager to sort of give people treatment later, just because I feel like.
Yeah, they've already gone through their period of risk.
Yep, that's what I was kind of thinking. But something to think about in, you know, something that we can think about in terms of strategies. And just the other thing, I'm so glad to see that the NCCN came out with those guidelines. Marianne, I hadn't seen that, but I think it's wonderful that they're saying now all triple negatives need to have genetic testing and that anybody who may be a candidate for olaparib should be getting genetic testing, so.
And I find that the more, even though, you know, we have this conversation about the USs and such, right? But the more we go towards something that is simple, the more likely we'll catch everybody, and the minority specifically. I find that you have a higher risk of losing them if you don't say, you know what, just spit in the tube, let's go.
I just actually recently, because of the Olympia data, tested somebody with a triple negative breast cancer, and she's got a BRCA1 mutation, 65-year-old triple negative breast cancer, really minimal family history.
And I think 0.6 is the number Dr. Kurian had come up with, right, for women over 60. If you look across the, you know, family history, no family history, or whatever, 0.6%.
And
what are your thoughts about this idea of having the consenting process up front? Now that we know we may actually need to test 600 women a year and follow up with the women who you guys are following at 6 months, at a year that didn't get to genetics yet. How do we go about doing that? Because it's a lot more patients compared to patients we have seen before.
Yeah, I think it's really interesting. And I was going to ask you what you thought in terms of how many patients, what the increase you thought it would be. You know, I think you guys are all spectacular and I love it when you get to talk to our patients. And the only thing I would say is just that even when people have negative results, I feel like that they oftentimes do benefit from conversation, just especially when they do have family history otherwise, or they have other cancers in the family that as breast cancer doctors, I don't think sometimes we do as good of a job of thinking about sort of what risk stratification they should have for screening for other cancers. So I think that that's maybe the piece where I don't know if there's a little bit of a triage or a tree point that we could think about in terms of who would, even with negative testing, still see genetics.
Yeah, we could very well see, people fill out the questionnaires and things to create a tree, right? And there's easier way to do this. It's hard enough when you have to try it out. But going forward, I don't know if in genetics we can see everybody, right? The 9 out of 10 who actually we could review and say, okay, out of those 100 or 200, maybe we need to see 17, right? Or based on this family tree or whatever VUS came up. But for the positive, maybe focusing our attention on them, if we have, let's say, out of the 600 new patients a year, you'll have 60. And then the ones that are going to come back for their follow-up, or they're going to be a candidate for PARP, and then you're going to do the tumor profiling and find the BRC frame shift, then these people will need to come. So I find that to accommodate all of these extra new patients, Mercy and I, and the team, I think we have to divide and conquer in a way.
And the only other thing I'll say, and something that I feel like I've seen in BOCP, and just something I'm very sensitive to is, and you brought up, is just sort of the widening disparities as we get more and more sort of high-tech, high-touch sort of information. And I think that people who have really high medical literacy and feel comfortable in the medical system are able to access a lot of that. And I think that again, the fact that less than 2% of the referrals are coming from Harborview. And I think if you looked by language or race or a number of other things, you would find sort of similar disparities. And I guess I'm wondering if there's something that we can do in terms of sort of safeguarding that and maybe taking a particular, some attention to that piece, so that we're not only capturing sort of well-off folks.
Yeah. Mercy and I are working, and obviously led by Mercy right now, the hereditary cancer group, and helping have more visibility or presence at different locations, Harborview specifically, because if you're there and people see you, it becomes more normal or part of the deal, rather than if you have Dr. Linda and say, oh, here you go, come here, we need you to get genetic testing, it's most likely going to, if they don't come back or something happens with their phone, it's going to, be over or not happen.
Just in terms of that, if the video is only in English, then that only captures our English population. And, so I think that for non-English speaking populations, we really need to be thoughtful, and it probably actually does require an in-person visit. Maybe that's something that we put into that as well.
Mercy, you can share. I think Mercy wrote something.
Yeah, I just want to add that we're doing our best to see if our SCCA genetic counselors can have Harborview privileges, because one of the gaps we're experiencing is that patients don't have a computer when they are home or a phone, so they don't follow through with the recommendation to see a genetic counselor. So Dr. Linden is really helping champion as our MD supporter to really have a genetic counselor be able to see patients while she is at Harborview. So it's sort of like a tandem appointment with an MD provider there. So more to come on that effort, but this is really one of our top priorities to serve those patient population.
And I find that, if we can, when we talk with them, if we can do both pieces together, right? This idea that we should all be doing, enrolling them in a predisposition registry or something, or high risk database, so we can actually use their information or things later on. I know it has a lot of challenges and all, but that if we miss that opportunity, it's just too bad, because we'll continue having much more enrollment of people of white descent.
And then one other thing that you didn't touch on, but I was just curious about is sort of the, I don't know, I call it the Mary Claire King study, just the research study looking at people who are negative and trying to capture those people to gather the information. And one specific question I'm just going to throw out there is I think that it doesn't include women who've had DCIS in the study. And I guess I'm just wondering, because in a family history that has like a fair amount of invasive cancer and then another DCIS, and especially early onset DCIS, where we think of DCIS as sort of equivalent in terms of risk for BRCAs and other things. And so I'm just wondering why that is, and maybe just asking if there's, if you guys routinely, I think you oftentimes routinely hook people in, but again, I think that there are some missed opportunities sort of between our patients and getting them into that research.
Yeah, definitely. And I don't think they are, and Mercy, correct me if I'm wrong, or Lauren, but I don't think they are enrolling DCIS. And there is in that British Journal of Cancer paper, there is a significant correlation. I forgot, actually, I need to go back, but like most often, if you have a predisposition, it's predicting, right? It's not just this DCIS. And so if you could actually highlight some of those things from that and learn from those patients, maybe some of these things would be applicable to more. And I think Dr. Kurian also had an abstract last year, if I remember correctly, where ATM came up as a risk factor for DCIS. And I need to go back and check where that publication has gone, but possible that there are some markers, and ATM-CHEK2, I think, have panned out for estrogen receptor positive breast cancers compared to the other ones. So maybe that actually is, differentially important in a way.
I just wanted to add a quick update too for those who might not have heard that about the email from Jessica Mandel with Mary Claire King's group, that they've expanded to enrolling triple-negative breast cancer patients under age 35 without family history if their genetic test result was negative. So not that many, I guess, in that young age group, but at least it lets us sneak a few more people in.
No, that's really great to hear. I mean, I was asking in particular because I have a patient who's, I think, 44. Her sister had breast cancer at 39 and their mom had DCIS at 50. And to me, that still feels, and their genetics are all negative. And so I am still, anyway. But
I'll also add, if it's a non-white patient, I often find they're willing to relax the criteria more. So never hurts to ask.
Well, I think we're almost at time. This was such an incredible talk, Marianne. Thank you so much. And it was so great to see so many of our genetic colleagues on the line. I think that there are a number of people who are on vacation from our end, but it was awesome. And I think it's being recorded, so people will be able to go back and look at it. It's really a wealth of information. So thank you.
Thanks very much, Marianne, and thanks, Rachel, for assistance today.
Of course, my pleasure.
Thanks, bye.
Take care, guys.